You're good, Hital. You can start.
Okay. A very good evening to all of you. Hetal Gohil here from Medical Services Department of Hetero Healthcare. On behalf of Hetero Healthcare, I would like to welcome you all for this very informative webinar on Vonoprazan, the first-in-class PCAB for acid-related diseases. Hetero Healthcare is an innovative pharmaceutical company since more than 3 decades, which caters to around 14 plus therapeutic areas aiming to improve patients' quality of life. Hetero was majorly involved in tackling the national emergencies such as swine flu in 2005 and COVID-19 epidemic with the drugs such as remdesivir, favipiravir, and nirmatrelvir. This was possible only due to strong R&D facilities and state-of-art manufacturing facilities that have ensured the seamless supply of medicines. As a solution provider, we always believe that manufacturing of the newer medicines are an integral part of uplifting human life. Currently available proton pump inhibitors represent the mainstay of the therapeutic management of acid-related diseases such as gastroesophageal reflux disease, peptic ulcer disease, and H. pylori infection. However, it is found that around 50% of GERD patients have reported an inadequate response to the conventional PPIs. Due to several unmet needs in this management, it was essential to develop a novel drug to improve the clinical outcomes of such acid-related disease. Hetero has again established its role in bringing newer solution for the first time in India with Vonoprazan in managing acid-related diseases. Vonoprazan, the first-in-class potassium competitive acid blocker, that is PCAB, has shown or has been approved for GERD, peptic ulcer disease, reflux esophagitis, and H. pylori infection in Japan in 2015 and in China 2019, and recently the US FDA has approved Vonoprazan in 2023. Vonoprazan has shown several unique advantages over conventional PPIs, such as rapid onset of action without requiring acid activation and full effect from the very first dose, more potent and prolonged inhibition of acid secretion for up to 24 hours, including a better nighttime control, meal independent anti-secretory activity, and favorable safety and tolerability profile in the long-term studies. PPIs need to be taken on empty stomach or 30 minutes before food. Vonoprazan, unlike PPIs, can be taken with or without, that is, before and after food. And most of the doctors have coined Vonoprazan as an 11 a.m. drug, which can be taken after breakfast along with other prescribed medications. To discuss the potential role of vonoprazan in managing acid-related disease, I would like to invite the speaker of this webinar, one of the eminent Dr. Apurva Shah. Currently, he is working as a senior consultant gastroenterologist and liver transplant physician at Apollo Hospitals, Ahmedabad. He is the member of all the major gastroenterological societies such as Indian National Association for Study of Liver, Indian Society of Gastroenterology, American Gastroenterological Association, and Society of Gastrointestinal Endoscopy of India. He has presented 35 plus poster presentations, oral presentation at various national and international conferences. He has been the author of various liver transplantation book chapters and has 20 plus publication in the index medical journals. He is the recipient of several awards, such as Emerging Consultant Award on Doctor's Day by Apollo Hospitals International Limited, Ahmedabad in the year 2022, Academic Achievements Award for the recognition of published papers in index journals in the year 2019 and in the year 2020 by Dr. Pratap Reddy, the founder chairman of the Apollo Hospitals Group. He also won the first prize for inflammatory bowel disease quiz held at PD Hinduja Hospital, Mumbai in the year 2014. He also won the first prize for 19th IAP Pediatric Quiz held at Jamnagar, Gujarat in the year 2006. With this, I would like to hand over the session to Dr. Apurva Shah. Over to you, sir, and I sincerely thank everyone for joining us this Friday evening. Thank you all. Over to you, sir.
Thank you, Ms. Hetta, for nice introduction. And good evening, all colleagues, friends, and juniors for today's webinar on Vonoprazan. So I'm just sharing my screen. So is it visible?
Yes, sir.
Okay. So today we are discussing a new molecule, Vonoprazan, first in class potassium competitive acid blocker for acid-related diseases. So slides visible now?
Yes, sir.
Okay. So we are discussing what are the acid-related diseases. So gastroesophageal reflux disease, erosive esophagitis, Barrett's esophagus, peptic ulcer diseases, which includes gastric ulcers and duodenal ulcers, Helicobacter pylori infection, and Zollinger-Ellison syndrome. So why we are discussing this topic today? So as we all know, for GERD and peptic ulcer diseases, the proton pump inhibitors remains the mainstay of treatment. But with the current available PPIs, there are some limitations. The drugs only acts on proton pumps which are active. These PPIs don't competitively inhibit acid secretion. So 50% of the GERD patients are resistant or having a partial response to the PPI therapy. The other problem is the onset of action. So as we give the PPIs, it will take approximately 3 to 5 days for achieving optimal effects. So more frequent doses of PPIs twice daily generally needed for getting optimal acid suppression as well as symptom relief. Another problem is these are the drugs which acts under acidic conditions, unstable under acidic conditions. So the preparations which are required, they should be made enteric coated preparations because they are not stable in the acidic conditions. Other thing is, even though they block the proton pump inhibitors, but they are not able to keep the gastric acid pH above 4 for a long period of time, maybe 24 hours. So because of this, there is a nocturnal acid breakthrough. That means patient have symptoms of GERD at night time once the effect of PPI will go away. So there are three specific concerns with PPI therapy. That is drug-drug interaction with clopidogrel. On long run of PPIs, there are certain studies which are putting the increased risk of fractures, hypomagnesemia, and low vitamin B12 levels. So with current available therapies, there are certain limitations of the proton pump inhibitors. So we have been looking for some other options always when there is no response to PPI in GERD patients. So luckily, after many research, we have got some new molecule after many years, which can be used in GERD patients. So failure of PPI therapy results in persistence of symptoms, occurrence of new symptoms, and relapse of healed esophagitis during maintenance therapy. So this is the chart how the evolution of acid suppression therapy has been done. So since 19th century, the only medicines available are the lifestyle interventions and antacids, which are aluminum and magnesium containing antacids. In 1970s, there is a breakthrough, very good research have shown availability of H receptor antagonists, cimetidine, ranitidine, famotidine, and nizatidine. So these are the group of the drugs which have shown to have significant effect on acid separation. Then comes the prokinetics and 1980s, which are a major research where availability of the proton pump inhibitors are there, which we are using at present, which is a mainstay of GERD. Till now, the drug molecules are omeprazole, abeprazole, pantoprazole, lansoprazole, dexlansoprazole. So these are the group of the molecules which we are using just at present. And now we have new molecules which is known as Vonoprazan. So what is PCABs? So it is a potassium competitive acid blockers. So it's not a new molecule. It is developed in 1980s. So what it does? So the mechanism is it competitively and reversibly blocks the potassium binding side of gastric proton pump. So again, this drug is also acting on a same proton pump, but the mechanism is slightly different from the proton pump inhibitors. So in initial clinical development phases, they've showed there is rapid onset of action, good accumulation of the drug in the gastric glands with slower clearance than PPI, which leads to longer duration of effect, rapid onset of action, and from the first dose, you can see the maximum effects. Apart like PPI, which takes 3 to 5 days. So the molecule is Vonoprazan. It is first in class of potassium competitive acid blockers. It shows full effect from the first dose in reflux esophagitis, peptic ulcer diseases, both gastric and duodenal ulcers, NSAIDs or low dose aspirin induced ulcers, and H. pylori infections. So this is the molecules which was developed by Takeda Japan in Feb 2015. It's already approved for the treatment and prevention of various acid-related disorders like GERD, erosive esophagitis, reflux esophagitis, peptic ulcer disease, and H. pylori eradication. In 2019, this drug is approved in China for the same indications, peptic ulcer disease and reflux esophagitis. And in November 2023, the US FDA has approved this drug, Vonoprazan, again for the same treatment of GERD as well as treatment of combination therapy for eradication of H. pylori gastritis. Recently, 2 months back in May 2024, the DCGI has approved Vonoprazan also in India for the same indications as I have mentioned previously. So this is the developmental milestone how this drug has developed. It was already available in Japan since 2015, but now in this year, DCGI has approved the use of Vonoprazan in India. So what are the key points for Vonoprazan? So this is the drug, it inhibits the proton pump in a reversible manner. The full anti-secretory effect can be we get from the first dose, does not require acid activation. It is a rapid acting, strong and continuous gastric acid suppression as compared to esomeprazole and abeprazole. Increase of intragastric pH to more than 4 within 4 hours. The good thing is that it's a longer duration of action. More stable in acidic environment, unlike PPI. So the nocturnal acid breakthrough can be prevented. And other more advantage of this drug is that when we take PPI, it has to be taken half an hour to 1 hour before the breakfast or meal. But this drug you can take irrespective. We can take with food or without food. If we see the pharmacokinetics of this new drug, so Cmax is 10 to 16 nanogram per ml. Metabolism, it is metabolized in the liver by cytochrome P450. PK is more than 9. That is why it allows a high level of accumulation in the canaliculi of the parietal cells. See the half-life, it is almost more than 7 hours and it is excreted through the kidney. So if we see, compare the mechanism of PPI versus vonoprazan. So what PPIs does? So this is a picture which is showing proton pump H plus K plus ATPase on the parietal cells. So what PPI does? So PPI basically attached to the newly surfaced proton pumps. So what happens? Which are inactive H plus K plus ATPase? It will not inhibit them. While vonoprazan, it functionally inhibits the proton pump as a result of competing with the binding of potassium ions. So that's why it's different from the proton pump inhibitors. So this drug competitively competes with the potassium and binds at the proton pumps. So what are the indication and dosages? So if we see the dosages for the treatment, either you are seeing it for the GERD or reflux esophagitis or for the proton or for the peptic ulcer disease. The treatment dose remains 20 milligram daily for 8 weeks. If we talk about maintenance of the therapy after achieving the remission of reflux esophagitis or healing of ulcer, so the maintenance dose is 10 milligram daily, and the duration generally recommended is for 6 months. So give 20 milligram OD dose, oral dose tablet is available for 2 months. Maintenance therapy 10 milligram OD for at least 6 months. Second use is prevention. Prevention of recurrence of gastric ulcer or duodenal ulcer when patient is on NSAIDs or aspirin. So the prevention dose is only 10 milligram daily. You can use it up to 6 months. Another important use is adjuvant to the H. pylori infection. So till now, H. pylori infection, we are giving different kind of things, maybe using sequential therapy, quadruple therapy, triple therapy, which requires 2 antibiotics with PPI. But now, with availability of this vonoprazan, now we can reduce the pill burden. So it is effective in H. pylori also. So we'll do further for the H. pylori infection, how it can be used with which dosages. So what about the dosages in the special population? So when we are talking about special population, we are mainly worried for the two special patient population. One is kidney and liver. So any patient who has got renal impairment, so less than 30 ml per minute of GFR, you require the dose to be 10 milligram rather than 20 milligram daily. So any patient whose GFR is more than 30, you can continue with the normal dose of 20 milligram daily. But if GFR is less than 30, the dose required is 10 milligram daily. Similar for hepatic impairment, if patient has got child A cirrhosis, no dose adjustment is required. But if there is decompensated cirrhosis, that means if child class B or child class C, then the dose of the drug should be 10 milligram daily. So in both severe renal impairment, when the GFR is less than 30, you require to give only 10 milligram per day dose. And in hepatic impairment also, decompensated cirrhosis, you require to give only 10 milligram per OD dosages. And this dosage is only for the GERD and peptic ulcer disease. When patient has got H. pylori and hepatic or renal impairment, at present, the drug usage is not recommended. As you can see from this slide, if patient has got H. pylori infection and renal impairment, at present, less than 30 ml per minute GFR, the use is not recommended. So for H. pylori with renal or hepatic impairment, at present, the recommendation is not there. So it is only for patients with GERD and peptic ulcer disease. If patient has got renal or hepatic impairments. Apart from the dosages, other special population is pregnancy and lactation. So unfortunately, there is no clinical studies both in pregnancy and lactation is available. So at present, this drug is not recommended in both pregnant women and lactating women. Again, in pediatric population, again, safety and effectiveness is not established. Geriatric people, again, because in patients who has got 65 years or more age, because they have some reduced renal function, hepatic impairments in those cases, require to reduce the dose of 10 milligram per day rather than 20 milligram per day. Now, if we compare PPIs with vonoprazan, this is the chart which is showing as we are concerned with the actions, transformation to active form needed in case of PPI, while vonoprazan reacts directly. If you see the concentration of drug in the parietal cell acid space, PPIs 1,000-fold more elevated in plasma. As we are comparing it with the PPI, vonoprazan 1 lakh-fold more elevated than in the plasma. Again, the binding to the proton pump. In case of PPIs, it is irreversible, while vonoprazan, it reversibly binds to the proton pump. Half-life for PPI, it is less than 2 hours, and vonoprazan, it is approximately 7 hours. Anti-secretory activity is meal dependent in PPIs. You have to take it prior to the meal, half an hour to 1 hour. In case of vonoprazan, it does not require any food prediction. You can take with food or without food. The full effect of the drug in case of PPI will take 3 to 5 days, while in case of vonoprazan, it will be after first dose. Because of this pharmacodynamics, it acts more for 24 hours. The nocturnal breakthrough will be less. One important comparison is also that genetic polymorphism effect on PK. So PPIs are affected, while vonoprazan will not be affected. So this is the comparison, how vonoprazan is better than PPIs. Now, coming to the contraindication. So when we have a new drug, we have to know is there any specific contraindication for any drug. So patients with a known hypersensitivity or any component of vonoprazan, if there is sensitivity, you have to, this drug is not advisable, contraindication. Another important contraindication is if patient is taking antiretroviral drugs. So these antiretroviral drugs generally have a liver metabolism. So if this drug is used with vonoprazan, vonoprazan is generally reduces the absorption of these important antiretroviral drugs. So if any patient is taking etazanavir, nelfinavir, or rilpivirine, these are the antiretroviral drugs. Vonoprazan should not be prescribed with these drugs because there is a reduced absorption of this drug when vonoprazan is used. So this is the contraindication when vonoprazan should not be used. So this is the same thing as I have told you. Rilpivirine containing products, azatanavir and nelfinavir, these are the products where use of vonoprazan should be contraindicated. You should avoid vonoprazan in this group of patients. There are certain other group of drugs where there is changes in the metabolism are there because of CYP3 substrate inhibitors, but there is not much contraindication in this drug. So major contraindications remains antiretroviral drugs. So now we are coming to adverse effects. So when there is a availability of any new drug, we have to know whether is there any specific adverse effect or side effect of the drug or not when it is used for longer period of time. So in the trials, it has shown that it has very good safety profile and tolerability profile. Adverse reactions which are seen usually, they are usually mild and moderate and can be managed without any medications. No life-threatening side effect has been seen till now because this drug is already used in Japan, China, and since last year in US also. So no adverse effect has been seen in last 8 to 9 years with the vonoprazan. So what are the guidelines now? We have already talked about what is the mechanism, how it is advantage over the PPIs, what are the contraindications, in which dosages we have to give this drug, and good safety profile. Now, what guidelines recommend for the vonoprazan? So as it is recently available in India, so all the guidelines recommendations which were available are from the Japan usually because it is available since 2015. So if we see evidence-based clinical practice guidelines of GRD 2021, the Japanese Society of Gastroenterology, again, they have recommended that treatment for mild reflux esophagitis or PPI resistant mild reflux esophagitis. Initially, you have to give 20 milligram per day and maintenance 10 milligram per day. If there is severe reflux esophagitis, then 20 milligram vonoprazole for at least 8 weeks, followed by 10 milligram for maintenance. Then comes these guidelines also suggest that vonoprazan provide a potent and long-lasting inhibition of gastric acid secretion, and its efficacy is expected to be superior to that of the PPIs. Recent report had shown that triple therapy, including vonoprazan, is as effective as first-line and second-line therapies for the eradication of H. pylori. There are certain reports also indicate that vonoprazan effectively heals peptic ulcer, and there is prevention of recurrence of NSAIDs-induced or low-dose aspirin-related gastric or duodenal ulcers. Now, this is the guideline for management of H. pylori in Japan 2016, because it was already available there in 2016. So they have mentioned that standard eradication treatment for H. pylori in Japan is 7-day triple therapy with PPI, or they are using vonoprazan 20 milligram BD. Here, normal dose in reflux esophagitis is 20 milligram OD, but when you are using it for H. pylori, the dose is 20 milligram BD. So you have to get it twice daily, and it should be combined with amoxicillin 750 milligram BD and clarithromycin, or you can combine it with the metronidazole. What are the clinical evidences? So, vonoprazan once daily, effective and inferior to the lansoprazole 30 milligram in healing. So healing rate after 2 weeks of treatment is higher as compared to lansoprazole. So when we compare severe esophagitis, that is grade C and D, Los Angeles classification, this is an endoscopic classification of reflux esophagitis. So grade A, B, C, D. So grade C and D are considered as a severe reflux esophagitis. When patient is having severe forms of reflux esophagitis like grade C and D, in those group of patients, there is higher proportion of healing in vonoprazan group as compared to lansoprazole. And the recurrence rate is also low. So this is a summary of various studies which are available for the vonoprazan for the treatment of erosive esophagitis. Majority of the treatment consists of treatment duration of the 8 weeks with dose of 20 milligram OD, and excellent outcomes, more than 95% healing in majority of the trials. These are various trials which are available in Japan, Asia, China. This is one study where they have compared vonoprazole with lansoprazole for healing of erosive esophagitis. I have already told you that vonoprazan is superior in treating and healing of erosive esophagitis and also the recurrent CCS. The comparison at week 2 and week 6 and 8. So the conclusion of the study was vonoprazan is non-inferior to the lansoprazole. It is highly effective for the treatment of erosive esophagitis, mainly when they have a severe form of erosive esophagitis, like Los Angeles classification grade C and D. In long-term maintenance therapy also, vonoprazan 10 milligram, 20 milligram daily had shown low erosive esophagitis recurrence rate as compared to the PP. And it is very safe and well tolerated 1 year in the maintenance therapy for healing erosive esophagitis. So apart from comparing it with the lansoprazole, again, this is a comparison of vonoprazan when it compared with the esomeprazole or rabeprazole, again, randomized open label crossover study. Again, in this study also, they have shown that vonoprazan was significantly greater acid inhibitory effect as compared to the PPIs on day 1 and day 7. So rapid and sustained acid inhibitory effect as compared to PPIs. Now, coming to the Vonoprazan for eradication of H. pylori. As we know, H. pylori infection is a global health problem. No, it is a class 1 carcinogen classified by WHO, and in symptomatic patients with H. pylori, we require eradication. So currently, we are using mainly the triple therapy or concomitant therapy or sequential therapy. But now, because there are many studies are available with the Vonoprazan as a treatment for H. pylori infection, we can use this drug along with antibiotics for the H. pylori eradication. So these are the various studies for first-line H. pylori eradication where Vonoprazan has been used and compared it with the PPI-based regime. So you can see various studies where the eradication rates are slightly higher as compared to PPI-based regimes when Vonoprazan has been used. So these are all the studies which are comparing Vonoprazan-based regime in H. pylori as compared to PPI. So this is the same various studies for H. pylori. So Vonoprazan-based regime is safe and it is more efficacious as compared to PPI-based regimes for first-line therapy of H. pylori eradication. So this is one study where you can see long-term safety and effectiveness of Vonoprazan in patients who are on NSAIDs. This study was again carried out in Japan, and it has found that when you use Vonoprazan for prevention of ulcer in patients who are on NSAIDs or low-dose aspirin, it is safe. So is there any, this is a very good trial on QTC interval. Generally, we see if there is any cardiovascular safety of Vonoprazan. So this study has shown that the cardiovascular safety of Vonoprazan is excellent. There is no QT prolongation with this molecule. So if we see the summary, the currently available PPIs remains the mainstay for the therapeutic management of all acid-related diseases. In spite of that, there are, as we have seen, there are unmet clinical needs because of there is inadequate response to the PPI therapy in 20 to 40% of patients. There is slow onset of action in case of PPI, and it does not prevent nocturnal acid breakthrough. So for this problems, now we have a novel anti-secretory agent, which is of new class, potassium competitive acid blockers, known as Vonoprazan, and it is very effective in patients who has got resistant or refractory to the PPI, peptic ulcer diseases, and also for eradication of the H. pylori. As we have seen that it's already approved in Japan, China, and US FDA approved, and in this year it is also approved by DCG. And the good thing is that now this Vonoprazan drug is already available in the market since last 1 to 1.5 months, and we are already using these molecules. So introduced first time in India, it is able to exert direct and targeted effect on parietal cells, provide rapid, which is effective within the first dose, long-lasting inhibition of acid suppression, and doing control of nighttime symptoms. Healing rate of GRD and peptic ulcer diseases is very good, more than 90%. Again, when we see the H. pylori eradication, majority of the trials have shown 85 to 95% eradication rate with the Vonoprazan containing combination therapy. And as far as safety and tolerability is concerned, it is very safe and well tolerated, novel alternative for all acid-related diseases. Thank you.
Thank you, sir, for giving the detailed information on Vonoprazan. We have received few questions, so can we start with the Q&A session, sir?
Yeah, sure.
Okay. So the first question which we have received is, can we give vonoprazan along with prokinetics? Can we combine these two agents?
Yes, prokinetic can be combined with the vonoprazole. Unfortunately, as we have a fixed drug combination of PPI with prokinetic is available, but because this is a new molecule, at present we don't have a fixed drug combination of vonoprazole with prokinetics. But yes, we can use prokinetics like domperidone, metoclopramide, or etopride along with vonoprazole when there is an indication of prokinetics.
Okay, okay. What is the safety profile of vonoprazan? Clinically, I mean, what are
Yes,
the
yes.
clinical side effects of vonoprazan?
So there are no, as I have told you, in the trials, there is no major side effects are seen. And as far as practically when we are prescribing these molecules, we don't have received any major side effects. Sometimes short lasting diarrhea, nausea, this kind of non-specific symptoms we can get, but no specific major adverse effect with the vonoprazan. It's a very safe molecule.
Okay. The next question is, can vonoprazan be given to patients who are suffering from cardiac diseases?
Yes, I have told you that the cardiovascular safety is very good. So any patients who has got cardiac problems, we can give vonoprazan. There is no issue.
Okay. Can it be combined with antihypertensive or anti-diabetic medication, or have you started combining vonoprazan with any of such drug in your patients?
Yes, yes. So see, when we see the patients of GERD, generally majority of them have many comorbidities. They have hypertensive, having coronary artery disease or diabetic patients. So as far as drug-drug interaction is concerned, as I have told you, apart from antiretroviral drugs, there is no major drug-drug interaction of vonoprazan with other molecules. So at present, we are giving that, and again in the monogram or when you see the drug chart, in all the trials, there is no major problems when this drug is given with antihypertensive or antidiabetic medication. So yes, we are using in clinical practice this molecule with antihypertensive and antidiabetic medications.
Okay, okay, sir. The next question is, can vonoprazan be combined with antiplatelet therapy such as clopidogrel? As we have seen drug-drug interaction in the pack insert, I mean, the
Yes, yes, yes.
drug
So
detail.
yeah, so as like patients who are on clopidogrel, there are certain drug-drug interaction with the PPI, but this kind of drug interaction will not be seen with vonoprazan. So absolutely, you can use this molecule once daily along with any antiplatelet which is available at present in the market.
Okay, okay. Sir, is there any report of vonoprazan in children that is between 12 to 18 years of age?
As far as I've told you, there is no much trials which are conducted in the pediatric population. So at present, this drug is only for the adults. So as far as pregnancy, lactation, and children are concerned, the drug uses is not recommended at this point of time, unless we have some more studies.
Okay, okay. Since the risk of fractures and osteopenia have been observed with PPI therapy in long term, is there any risk of such, risk? I mean, is there any risk of getting such problems when vonoprazan is given to patients for long term? I mean,
Yeah, yeah. So as we have seen that long-term PPI has got its own side effect of this kind of things. See, when we give vonoprazan also, we will be thinking in terms that both the drugs are inhibiting the acid only, right? Major action is to inhibition of the acids. So whenever we get inhibition of the acid for a longer period of time, there are certain molecules like magnesium, B12, these are the efficiencies going to happen, even if it is PPI or vonoprazan. So those kind of things should be taken care when patient is around long-term duration. But as far as fracture, osteoporosis, this kind of side effects are concerned, till now on vonoprazan, there is no such kind of warning has been seen, or no data is available till all the studies are available that vonoprazan increases the risk of any one disease, osteoporosis or fracture.
Okay, okay. The next question is there any side effect related to pharyngitis and with vonoprazan, especially when used in GERD patients?
Yeah, so usually drug-induced pharyngitis is very less as far as vonoprazan is concerned. So practically, we are not seeing the patients who has got pharyngitis because of the drug vonoprazan.
Okay, so the next question is can vonoprazan be given to patients who are suffering with liver cirrhosis?
Yes. So in liver cirrhosis patients, vonoprazan can be used, but you have to be cautious regarding the stage of the liver cirrhosis. So if they are compensated cirrhosis like child A cirrhosis, then you can use vonoprazan with the normal dose of 20 milligram per day. But if they are decompensated cirrhosis like child B or child C, then in those group of patients, the dose of the vonoprazan should be 10 milligram per day. But it is not contraindicated. You can use this molecule even in decompensated cirrhosis, but at a reduced dose.
Okay, so I mean, since the dosage guideline says that it can be given as once daily dosage for prophylaxis and twice daily dosing when the patient is suffering with H. pylori infection, are there any clinical reports where thrice daily dosing of vonoprazan is given, or any doctor is giving such higher dose?
See, because it's a reversibly inhibiting proton pump inhibitors, and if you see the potency of this drug of vonoprazan as compared to PPI, it is, I will say, 1,000 times more potent than the PPI because this drug is concentrating on the canaliculus of the parental cells. So when we are using this kind of molecule, that kind of dosages are generally not required. And in all the trials also, when we are using vonoprazan for GERD or peptic ulcer disease, the dose OD dose is always sufficient. The only recommended BD dose is only for the H. pylori infection, where we require higher acid suppression. So TDS dose is not recommended in any of the studies or guidelines, but yes, OD dose for the treatment of GERD and peptic ulcer diseases, and BD doses for the H. pylori indication.
Okay, so is there any need to monitor magnesium level as it reduces or it causes hypomagnesemia in patients?
Yes, ideally, if this drug is used for more than 6 months, ideally magnesium and B12 levels should be checked, and if they are low, we should replace them.
Okay. There's one more question, which is what is your clinical experience with vonoprazan and how your patients have responded to vonoprazan therapy?
Yes, so because this drug is available since last 1.5 months almost now, so whatever we get the patient related outcomes, so patients are very happy who has seen that. Unfortunately, I have not seen the objective assessment. Like I have done the repeat endoscopy and I've seen the healing of erosive esophagitis because drug is not available for longer period of time now. So because of that short duration, I will be able to tell the patient reported outcomes, and they are good. There is no major side effect. Patient are tolerating and they are getting good symptomatic relief with the molecule. Yes, objective assessment by before giving vonoprazan and after giving vonoprazan, endoscopic healing of erosive esophagitis, we have not seen because of the short duration of just availability of the drug.
Okay, okay. So the next question is since we already know what are the approved indications, what, according to you, what can be the other conditions or some off-label use of vonoprazan? Is there any other conditions where we can use it
Okay,
apart from the approved indication?
yeah, so if you say off-label indications, there is one indications which I can recommend is the chronic pancreatitis patients. So when patients of chronic pancreatitis are taking the pancreatic enzyme replacement therapy, these are the patients has been receiving PPI regularly. Okay, that is compulsory because of the preparations. When which kind of preparation they are using. So when they are using the antric coated preparations, you require PPI for their activation. So in those group of patients who are on PPI on pancreatic enzyme replacement therapy, this is the drug you can use, which is more uh, rapid onset of action, and because of the longer duration of action. Uh, Instead of PPI, this drug can be used in patients with pancreatitis who are on enzyme replacement therapy.
Okay, sir. Okay. Sir, we have finished with the questions. So
Okay.
there are no further questions. I mean, you can just summarize the session, sir.
Okay. First of all, thank you, Vitro Pharma, for organizing such a nice webinar on this monsoon season. So summarize my talk. So currently available PPIs, as we see, 20 to 40% of the patient in our clinical practice are generally resistant or not tolerable with the PPI therapy. They are not getting symptomatic relief. So generally in severe forms of gastroesophageal diseases, peptic ulcer diseases, and H. pylori eradication therapy, uh, it is advisable now and recommended that we can use the Vonoprazan instead of PPI in severe forms of erosive esophagitis because of its rapid onset of action, longer duration of action, without any drug-drug interaction, OD dosing schedule. So these are some of the advantages over. Again, availability of the this drug will change the H. pylori management also, because there is a recent study published uh, in American Journal of Gastroenterology that 10 days course of twice daily vonoprazole along with amoxicillin 1 gram TDS, only two drugs, 10 days course will as sufficient and efficacious as compared to triple therapy given for 14 days. So availability of this drug will also reduce the pill burden and achieve higher rates of H. pylori eradication as compared to PPI based combination therapy.
Thank you very much, sir. Thank you for the detailed information on vonoprazan and patiently answering our queries. Yes,
Yeah.
Vikram.
Yeah. So thank you, doctor. Uh, so entire participants, attendees, as we draw this enlightening webinar to a close, it is my privilege to extend our heartfelt gratitude to all those who have made this event a success. We have received more than 550 plus registrations. At the same time, we have been able to see that 200 plus more than doctors have been live on this Friday evening post 8:30. So, firstly, a huge thanks to our esteemed speaker, Dr. Apurva Shah, one of the leading gastroenterologists of Ahmedabad, whose insightful presentation and thought-provoking discussions have enriched our understanding of Vonoprazan, which is first-in-class PCAB. I would also like to express our deep appreciation to our participants, attendees for their gracious presence despite of their busy schedule, and thank you for active participation and engaging questions. We have seen wonderful questions coming up, which is more of clinical relevance rather than being theoretical. I would also like to thank our Senior Vice President, Sir, Mr. Nehru Dadi Sethi, Sir, for his support and guidance for the webinar, and also thank our dedicated organizing team, our sales head, Mr. Amit Rathod, and Mr. Rajendra Arora, and the entire field force of Hetero Healthcare Gastrocare Division. I would also like to thank our medical advisor, Ms. Hetal Gohil, for the wonderful medical assistance giving us and being the backbone of this webinar, along with our IT team under the leadership of Mr. Chiranjeevi, Mr. Vijay Chilukoti, Giridhar, Maheshwari, and entire PMT team for their exceptional efforts and attention to details. The entire scientific session was sponsored by Hetero Healthcare, makers of vocab. As we conclude, We hope you leave with new insights and learnings. Please feel free to reach out to us or our team members for any feedbacks or further questions. We look forward to welcoming you to our future events. Thank you once again for your gracious presence and participation. Thank you.
Thank you, Vikrant, Hital, entire Hitro team, and all the listeners for this evening. Thank you.
Thank you. Thank you, Dr. Apurva.
Thank you, sir.